Good morning, respected Emeritus Chairperson, sir, esteemed dignitaries, respected faculty members, and dear colleagues. Imagine boarding an aircraft and hearing the announcement, we skipped the pre-flight safety checklist because everything looked fine. Would you board that aircraft? The pre-anesthetic evaluation is our pre-flight safety checklist. It identifies hidden dangers, prepares for emergencies, and ensures that when the patient enters the operating room, we are prepared for every possibility. As Sir William Osler wisely said, listen to your patient, he is telling you the diagnosis. Similarly, long before the patient enters the operating room, a systematic, comprehensive, and individualized pre-anesthetic evaluation tells us how to anesthetize the patient safely. The American Society of Anaesthesiologists defines pre-anesthetic evaluation as the process of clinical assessment that precedes the administration of anesthesia, which is aimed at identifying patient-related, surgery-related, and anesthesia-related factors that influence the perioperative outcome. Many people mistakenly believe that pre-anesthetic evaluation simply means declaring the patient fit for surgery. It cannot be farther from the truth. In reality, pre-anesthetic evaluation is a dynamic process of perioperative risk assessment, optimization, planning, communication, and shared decision making. So why is pre-anesthetic evaluation so important? The perioperative period represents one of the greatest physiological stressors that a patient experiences. Anesthesia profoundly affects cardiovascular function, respiratory function, neurological status, endocrine and renal responses, thermoregulation, and a dual insult where the surgery triggers stress hormone release, inflammatory cascades, blood loss, fluid shifts, pain, and hypercoagulability. So, can this patient tolerate the combined stress of anesthesia and surgery? The patient's ability to tolerate these physiological insults depends largely on their functional reserve, which varies considerably among individuals, and the pre-anesthetic evaluation helps us determine it. The benefits to the patient involve a safer surgery, faster recovery, and fewer complications, and to the healthcare system, fewer cancellation of surgeries, better resource utilization, and lower overall costs. So are all PACs the same? No. Elective PACs are a comprehensive evaluation. We optimize comorbidities. We have a complete panel of investigations. We do adequate fasting. We have a plan for anesthesia, and the surgery may be postponed for optimization. Whereas an emergency PAC is a focused rapid assessment. We stabilize life-threatening conditions. We do only essential investigations. We assume that the patient is full stomach. It is urgency-driven anesthesia, and the surgery usually proceeds despite incomplete optimization. So the 5 pillars of pre-anesthetic evaluation are to identify, to assess, to optimize, to plan, and to communicate. The first pillar is to identify. Anticipating anesthetic challenges such as difficult airway, low cardiopulmonary reserve, drug allergies, previous anesthesia complications, coexisting diseases, and ongoing medical therapies. It also helps us identify the undiagnosed conditions via the detailed history, examination, and targeted investigations. The second pillar is to assess the physiological reserve of the patient and stratify the risk using standardized tools. We hereby get a detailed and individualized preview to the patient's physical status and what we might expect in the operating room. The most crucial step to the pre-anesthetic evaluation is the journey of a patient, a high-risk patient, to a safer surgical candidate. We do this by optimizing and managing hemodynamics, treating active infections, and stabilizing critical conditions. The fourth pillar is planning. We are putting the patient to sleep. Let's make sure they remain comfortable. The patient needs an exhaustive anesthesia plan, which is determining general anesthesia versus regional anesthesia, a targeted airway strategy, multimodal analgesia requirements, monitoring and invasive lines, blood product preparation, and ICU stay preparations. The fifth pillar is to communicate. The patient often fears not waking up, pain, paralysis, awareness, post-operative nausea, and ICU admission. So, the process of counseling helps us reduce anxiety, build clinical trust, and informed consent is ensured, and improve post-operative cooperation. It is a multidisciplinary approach in between the surgeon, the anesthesiologist, physicians, cardiologists, pulmonologists, critical care experts, and the nursing. A stepwise approach to the patient involves a detailed history taking, physical examination, airway assessment, systemic evaluation, investigations, and anesthetic plan determining the risk grade, and active consenting. This is the pre-anesthetic checkup form from our hospital. It involves, firstly, the patient particulars. This may appear simple, but it is the foundation to patient safety. Correct identification prevents wrong patient, wrong site surgeries. Age influences physiological reserve, drug metabolism, and anesthetic techniques. Extremes of age group fall in vulnerable physiological reserve and require detailed assessment. Weight is an essential part for calculating accurate doses of anesthetic drugs, especially in pediatric patients. This is the picture of the section where we document the history. For example, eliciting an acute symptom such as cough may not raise warning signs of a patient at rest, but under anesthesia, the same reactive airway can precipitate serious complications like bronchospasm and desaturation, and thus require optimal optimization. The other avenues of history are to assess exercise tolerance, to determine coexisting diseases, to document event histories or accident histories, and do careful documentation for medico-legal purposes of previous surgery and anesthesia complications, genetic history, allergy history, also the substance abuse history, medication history, reproductive history, and in case of emergencies, the last meal. Here is how we document the general physical examination in the form. An interesting example here was a young female came for surgical excision of a lipoma. She was diagnosed with irregular pulse, which prompted further investigations. She was diagnosed with rheumatic heart disease and atrial fibrillation and managed accordingly preoperatively. The airway assessment is one of the most critical parts of pre-anesthetic evaluation. For example, abnormal dentition in the form of loose tooth can make the patient at risk for tooth dislodgement during intubation. Since it accounts for permanent disfigurement of anatomy, we need to do proper counseling and consenting. A proper airway assessment transforms an airway emergency into a planned airway strategy. These two diagrams depict the two scores. Malampatti score, as shown in the first diagram, is a simple, non-invasive method to help us anticipate a difficult airway. The second picture, the 3-3-2 anatomical guide, 3-finger mouth opening, 3-finger hyomental distance, and 3-finger thyromental distance, helps us determine and prepare for an airway difficult cart. In addition to a detailed systemic examination of the patient, we also assess the spine anatomy to determine feasibility for neuraxial anesthesia. Routine investigations are done for the patient preoperatively for a baseline biochemical status. Any derangement from the normal rays need further investigation and references to specific departments for optimization. Finally, we come to determining the American Society of Anaesthesiology's grade, which is to determine the overall physical status of the patient. It has 6 grades with an extended E for emergency procedures. Grade A normal healthy patient. Grade 2, a patient with mild systemic disease without substantial functional limitation. ASA grade 3, a patient with severe systemic disease with substantial functional limitations. Grade 4, a patient with severe systemic disease that is a constant threat to life. Grade 5, a moribund patient which is not expected to survive without the operation. And grade 6, a declared brain dead patient whose organs are being removed for the donor. The plan of anesthesia, the documentation of whether the procedure should be conducted in general anesthesia with endotracheal intubation, general anesthesia with supraglottic airway device, regional anesthesia, or just monitored anesthesia care. The pre-anesthetic advice accounts for the nil by mouth status, which is 6 hours for solids, 4 hours for breast milk, and 2 hours for clear liquids. We strongly discourage prolonged fasting. For blood preparation, ensuring that the blood products are cross-matched and confirmed. This is the standard anesthesia informed consent form in our hospital. It includes patient particulars, surgical procedure, counseling regarding planned method of anesthesia with benefits, risks and alternative methods. A guardian consent is taken in cases of minor, incapacitated adults and emergency care. This is the high-risk consent form from our hospital. Along with this consent, a handwritten consent in the patient's native language is obtained, which is specified to the patient, anesthesia concerns and type of surgery. Now that we have taken an overview on the extent of pre-anesthetic evaluation, let's now take a case-based approach to understand pre-anesthetic evaluation in a better light. Our first case is a patient with coronary artery disease. A 75-year-old male patient came to the hospital with complaints of rectal bleed and was diagnosed with rectal carcinoma and planned for abdominoperineal resection. He is a known case of coronary artery disease and hypertension. The patient was referred for a pre-anesthetic checkup. The patient complains of per-rectal bleed since 3 months. The patient complains of pain abdomen since 3 days. On past history, there was a sudden onset of centralized chest pain radiating to the left arm and jaw 9 months ago. On diagnosis, a coronary artery angiography was done and 85% stenosis in the left anterior descending artery was documented. He underwent a percutaneous coronary intervention with drug-eluting stent. Currently, the patient is on aspirin 75 mg OD, clopidogrel 75 mg OD, atorvastatin 40 mg OD and telmisartan 40 mg OD. Preoperative investigations were requested. The anesthesia concerns for this patient are perioperative major adverse cardiac events. There is a coagulation tightrope, there is a risk of bleeding due to the ongoing antiplatelet therapy, and there is a risk of stent rethrombosis if the medications are stopped. Furthermore, there are systemic stressors in the form of hemodynamic instability, sympathetic stimulation and arrhythmias. Since our patient has a known cardiac history and is on dual antiplatelet therapy, we referred the patient to the Department of Cardiology for cardiac risk stratification and further management. I would like to invite Dr. Jatin from the Department of Cardiology to take the case further.
Thank you, Dr. Ananya. Myself, Dr. Jatin Garg from Department of Cardiology, under the guidance of Professor Dr. Rajiv Sharma, and I am going to take the case further from the cardiac aspect. We discussed the 7 cardinal steps of the cardiac evaluation based on the 2024 AHA and ACC guidelines of the perioperative risk stratification. The step 1 is determining the surgical emergency. Step 2, ruling out the unstable cardiac condition.
AHA is American Heart Association. What is ACC?
American College of Cardiology.
बता दिया करो.
Okay, sir. 2024 American Heart Association and American College of Cardiology perioperative risk stratification. The step 1 is determining the surgical emergency. Step 2, ruling out the unstable cardiac conditions. Step 3, categorizing the surgical procedure risk. Step 4, assessing the functional status of the patient. Step 5, estimation of perioperative cardiac risk. 6, biomarkers and advanced cardiac testing. 7, perioperative medical therapy modification. If surgery is emergency, means immediate threat, the surgery needs to be done less than 2 hours. If the surgery is urgent, threat to limb or surgical intervention, the surgery needs to be taken within 24 hours. If the surgery is time sensitive, the surgery can be delayed up to 3 months. And if the surgery is elective, then the complete evaluation needs to be done. So going by this algorithm, if the surgery is urgent, the surgery needs to be done immediately. Moving to step 2. First we rule out the unstable cardiac conditions like acute coronary syndromes, unstable cardiac arrhythmias and decompensated heart failure. Because for these conditions we need the multidisciplinary approach and multifaceted approach to treat the condition. If there is no such condition, we move to step 3. Now, categorizing the surgical procedure risk, because they also have tendency of increasing the hemodynamic shifts and the risk of blood loss. For example, low risk surgeries having the chance of less than 1%, like surgeries like breast surgeries, endoscopic surgeries, and cataract or dental surgeries. Intermediate risk, which is our case, abdominoperitoneal resection, head and neck, intraperitoneal and minor intrathoracic surgeries carry the risk of 1 to 5%, and high risk surgeries more than 5%, which include the major transplant surgeries and major vascular surgeries. Assessment of the functional status. It is the ability of the patient to carry out daily routine activities. If the patient is able to walk up 2 flights of stairs, it means the patient have the capacity of 4 metabolic equivalents. Another score is Duke Activity Status Index. If it is more than 34, it means the patient can handle the surgery very well. The parameters which are considered in these scores are...
How do you calculate METs?
Sir, metabolic equivalence is
apart from the climbing and other things, how do you...
Sir,
any objective method?
Sir, it is a VO2 max.
What is VO2?
See, VO2 max is the maximum oxygen consumed by the person in pursuing the...
Yes, but how will you measure that?
Sir, there is cardiopulmonary exercise testing, CPET. In this, we ask the patient to go for the brisk walking in a parameter in the 30-meter zone.
यही तो मैं पूछ रहा हूँ कि saturation test करते हो या फिर कोई treadmill करते हो, कुछ करते हो, क्या करते हो? How do you assess the METs?
Sir, metabolic equivalence, sir, उसको the patient develops symptoms, chest heaviness and dyspnea. Now coming to the functional status scores, the parameters of the functional status scores. The patient, for example, the patient is able to climb two sets of stairs, and walking on a level ground at the speed of 6 km per hour. The metabolic equivalence for his having, he can go to the surgery easily. Duke Activity Status Index. Walking indoors having the scores of 1.75, climbing a flight of stairs 5.5, run a short distance about 8. In our case, sir, I was coming to sir, CPET, yes sir, yes sir. Now coming to a tool called Revised Cardiac Risk Index. It is a modestly an ages-old tool to categorize the major adverse cardiovascular events during the surgery. It is having 6 points. 1, high risk surgery. Number 2, history of ischemic heart disease. Number 3, history of heart failure, history of CVA, diabetes mellitus, and pre-operative serum creatinine more than 2 mg per deciliter. In our case, the RCRI index of the patient is 2, having a chance of major adverse cardiovascular events about 6.6% elevated risk. Now we estimate the perioperative cardiac risk. Does the patient having any of these conditions like valvular heart disease, severe pulmonary hypertension, any history of congenital heart disease or CAD or CABG, stroke, any pacemaker implantation, and frail score for the elderly patients. For example, if the RCR index is low, the patient can straightforward go for the surgery. But in the cases where the risk is elevated, we advise ECG and ruling out the condition, cardiovascular condition, and check the functional status. If the functional status is normal, that the metabolic equivalence more than 4, we can go for the surgery. But if not, then we have to go for the biomarkers. If the other elevated risk modifiers and elevated cardiac risk factors are present, then we need to go for the further testing in the form of echocardiography and other dobutamine stress echo. As we said, we have to go for the further testing in the form of biomarkers, which are NT-proBNP, BNP, and cardiac troponins. Because these elevated more than 100 picogram per milliliter, they have the independent chance of causing the all-cause mortality and major adverse vascular events. If the biomarkers are normal, we can go for the surgery, but if not, then the multidisciplinary discussion is needed. As we said, if the findings are low risk on the echo, then we can go for the surgery, but the findings are high risk findings, then we have to go for the CT coronary angiography, dobutamine stress echo, and then further discuss with the multiple disciplinary approach. Perioperative medical therapy modification for our patient. Our patient is having hypertension and coronary artery disease, and stenting was done 9 months back, and he was on telmisartan 40 milligrams. The drug atorvastatin, which is a statin, needs to be continued. Telmisartan needs to be stopped 24 hours prior to the surgery because ACE inhibitors and ARBs interfere with the pre-anesthetic drugs. So we advise stopping of the ACE inhibitors and replacing it with a calcium channel blocker of a low dose. Antiplatelets, aspirin 75 mg needs to be continued. Clopidogrel, P2Y12 inhibitor, needs to be stopped 5 days before the surgery. In our case, the patient's history of stenting with drug-eluting stent was done 9 months back. So there is no need of the bridging therapy. Sir, in a case there is a stenting done within a period of 6 months, we advise if there is a risk of stent thrombosis, then we advise to bridge the patient's antiplatelet therapy with IV cangrelor. It is having a short half-life, about 5 to 6 minutes, and it can be stored comfortably 1 hour before the surgery. Now this is about the optimal.
But in non-cardiac surgeries,
yes sir,
here of course a different case. You stop the aspirin also.
So no, the latest 2024 guideline, aspirin needs to be continued.
Yeah, I was generally would ask you to stress upon this thing.
Yes sir.
That aspirin is not to be stopped.
Yes sir.
In any situation, that
yes sir. 75 mg is continued, sir.
And things have changed.
Yes sir. 20 guidelines. Yes sir. Now this is for about the optimal timing, which is the most troublesome part for the stopping the dual antiplatelet therapy. The optimal therapy of the time-sensitive non-cardiac surgery, if the POBA, plain old balloon angioplasty, has been done, the non-cardiac surgery can be delayed up to 14 days. If the bare metal stent was placed, the non-cardiac surgery can be delayed up to 30 days. If drug-eluting stent, which is the current scenario, if the acute coronary syndrome was for the patient, the non-cardiac surgery can be delayed up to 12 months or should be delayed. If the chronic coronary artery syndrome like unstable angina or stable angina was for the indication of the PTCA, then the surgery can be delayed up to 6 months. In our case, the surgery is a time-sensitive surgery and it was 9 months back, so we can continue with the aspirin and stop with the clopidogrel. Now the cardiac risk of the patient is, the patient status is normotensive, good functional status, the surgery type is time sensitive with intermediate risk, RCRI of 2, MACE score of 6.6%, metabolic equivalence more than 4, Duke activity status index more than 34. The risk modifiers which are present in my case are history of PTCA and hypertension. My preoperative advice for the patient is to continue the statins, stopping of telmisartan and replacing it with a calcium channel blocker of low dose 5 mg of amlodipine, continuation of aspirin, stoppage of clopidogrel 5 days before the surgery.
You can continue with beta blockers.
Sir, yes, it's a beta blocker. If already going on can be continued. New starting of the beta blockers is not advised, sir. It is against, it's having harmful effect. Too early BP pressure charting, arranging the blood products accordingly, nil per mouth, high risk informed consent. Now invite Dr. Devansh to discuss the case further.
Good morning, esteemed chairperson sir, respected faculty members and my fellow colleagues. I am Dr. Devansh Sharma, second year anesthesia resident, and today I will be presenting the second case scenario about pre-anesthesia evaluation in patient with chronic obstructive pulmonary disease and diabetes mellitus. Presenting the case of a 49-year-old male smoker who came to pre-anesthesia clinic with complaints of symptomatic cholecystectomy and is planned for elective laparoscopic cholecystectomy with two important comorbidities, that is chronic obstructive pulmonary disease and diabetes mellitus. This case highlights the importance of systematic preoperative assessment, optimization and perioperative planning in reducing postoperative pulmonary and metabolic complications. The patient presented with acute upper abdominal pain associated with 2 to 3 episodes of vomiting over the last 3 days. Clinical examination demonstrated right upper quadrant tenderness, which precipitated following the consumption of fatty meals. A 30-year